She did not say. Ms. Kerr said she would. Ms. Lewis did not say. And Ms. Edkins cannot attend. So
Somebody just put it on hold.
Dr. Ford said she would try to rearrange her schedule.
So if you're on the line, please do not put us on hold. If you need to get off, please just hang up and redial in later. What's that?
Just Dr. Ford said she would try to rearrange her schedule and make it. She might come.
Have we had a board member join the call? Have we had a board member join the call? John, why don't you ask Athena to call Dr. Ford, and is Ms. Atkins going to be here?
She indicated she could not be here.
Okay.
And I sent a text to Ms. Kerr.
Okay.
So just Dr. Ford?
Yeah.
And can you send one on to Dr. Ford?
Yes, actually I can do it from here. All right, we should get Dr. Ford should be on there in just a minute.
Oh, okay. That will give us a quorum, won't it?
Yes, it will.
Okay.
Hi, this is Dr. Ford.
Good afternoon. And Madam Chair, we have a quorum.
Okay, thank you. Just a general announcement that we normally make. Would you please put your phones on mute so that we don't get background noise? And please don't put us on hold because that usually puts through elevator music into the meeting. So that, I'm calling the meeting to order. And agenda item number 2 is public comment. Do we have anyone from the public that would like to testify? And if you do, please identify yourself for the record.
Yes, I would like to make a comment.
Could you identify?
For the record, my name is Dennis Spain. I'm the Chief Dental Officer for Nevada Dental Benefits. I'd like to speak to the recommendation that the advisory committee is going to consider today. I would like to bring a couple of items to perhaps the board's full attention that was not present at the discussion at the advisory committee. This has to do with the question number B3 as to whether or not the dental benefits are an obligation as part of the offering from the exchange or whether it's an optional benefit. The problem we're facing is that Nevada really is kind of a dental public health nightmare. We have, among our 3 to 5 year olds, we have a dental decay rate that's twice the national average. We have the 3rd highest dental disease rate among our 3rd graders. And we rank 51 out of 51 states for providing the least number of preventive dental visits. The need for dental insurance is a well-known and well-studied phenomenon. We know that people who have dental insurance are twice as likely to use preventive dental health services as those who do not have it. Proposal B3 really is also an underwriting poison pill. I've spent most of today trying to meeting with actuaries, including the ones from Milliman, who are doing a bulk of this work, as well as other underwriters, trying to figure out how B3 will distort the risk pool and change the underwriting for the dental plan as proposed by the exchange. The exchange has selected a dental plan which has no commercial parallel. We do not know how this out-of-pocket maximum is going to be applied, nor do we know what the actual cost figures for a medical necessity orthodontic benefit are. B3 makes it virtually impossible to take all of these variables and reach any sort of a conclusion. We do know that when rates are voluntary among a group, when the decision to choose is based upon a person's perception of or actual knowledge of needs, we end up with adverse selection. And in a dental plan, that represents about a 40 to 60% higher rate than we would normally charge for an equivalent policy designed with 100% coverage. This is an opportunity for the exchange, really a once-in-a-generation opportunity, to do something for the health of kids in Nevada. And if we don't do it, it's probably never going to come around again. The intent of the Affordable Care Act was that pediatric dental services was supposed to be an essential health benefit. If we make it optional inside the exchange, it does not match what is going to happen outside the exchange, which makes it doubly difficult for plans to design plans and price plans inside the exchange and outside the exchange, nor does it really address the issue of churn, where we have
Mr.
members.
King,
I realize. Let me close. I will close.
3 minutes.
Okay. I just think this is an unnecessary, self-inflicted misdirection, and I would like and urge the exchange to select either item B1 or perhaps more preferably item B2 rather than item B3. Thank you very much for your time.
Thank you very much for your testimony. Is there anyone else that would like to testify on the line? Hearing none, I'm going to close public comment and open agenda item number 3. The board members and the public have I think it's a 10-page document that was posted on the site this morning. And Mr. Hager, I'm going to let you walk through it and guide us through this discussion.
For the record, John Hager, and first I need to thank staff for working through this last week with the board reports and with setting up the the meetings. As you're aware, this report was posted this morning at 8:30. I realize it's 10 pages long and it's a lot to digest, but the committee meeting was yesterday, and we wanted to make sure that we provided a complete report. On page 2 of the report, we talk about the federal requirements. Both for on the exchange and off the exchange. The off the exchange requirement is a must purchase requirement. Individuals must purchase pediatric dental. However, that's measured in different ways. The first way is that a dental plan actually embeds the dental benefit within the plan. The second way is that if a carrier provides a plan that does not have the dental benefit, that they have a reasonable assurance to indicate that person has purchased a standalone dental product that has been certified by the exchange. They wouldn't purchase it through the exchange, they'd purchase it off the exchange, but they'd have to have that reasonable assurance. What we don't know is whether that reasonable assurance comes in the form of an attestation or if it is obtained simply by noticing the purchaser that the plan doesn't include dental, and we're working through that. There are 3 states that have indicated that the notice requirement is enough. But by and large, right now, most of the country is considering the attestation option. We don't know where Nevada is going to be at this point. The on the exchange requirement is that the dental benefit is offered, and so an individual could either choose a plan with dental embedded or bundled with the carrier medical plan, or if a plan excludes the dental essential health benefit, then the individual would be offered the opportunity to purchase a standalone dental plan. And so Mr. Spain's remarks went to the fact that you could require purchase. CCIO rules currently indicate that purchase is optional, but there are states that are requiring purchase. So back on March 14th of 2013, the exchange determined it would require all qualified health plans that provide the pediatric dental essential health benefit to separate the pricing out from the remainder of the health plan by submitting the dental benefit as a rider for that product. The exchange would not allow the pediatric dental EHB to be embedded in the qualified health plan. The board arrived at this policy decision basically because it allowed us to do a better apples-to-apples comparison of the dental benefits, and it avoided situations in which carriers set unrealistically high deductibles for dental benefits. We talked about the apples-to-apples comparison, and it's in the report on page 3, so I'm not going to go into great detail about that. However, I will say that we have confirmed with Xerox that regardless of which direction the board takes, that we are able to ensure that the individual consumer understands what benefits are available, both in the horizontal selection screen and then when you add it to the cart and do the vertical comparison screen. There are ways to show the dental benefits and that there are other dental options available in a follow-on selection screen. So we think that we've got that cleared up on the display side. And in the rest of it, there may be some selection issues with pricing, but that is generally seen as a positive. If you can provide a more efficient product, then go ahead and do so, I think is what the committee said yesterday. But we will go through the committee's recommendation in just a minute. The other part was the unrealistically high deductibles for dental benefits. There was a concern that a carrier could create a deductible for dental plans that was about the same as a medical plan, making it difficult for people to understand that perhaps an individual who purchased a plan, they didn't realize that the dental deductible was really high, and so you'd have a family that is otherwise healthy, but the kids have a couple of cavities. Those cavities would actually never be paid for by insurance. They would get the network discounted rate, but they wouldn't get any benefit because it would all go toward the deductible. We have since learned that kind of a design would be discriminatory benefit design. We're not sure exactly what would be considered not discriminatory, but rest assured, you would not see a plan with an extremely high dental deductible. It will be interesting to see what we end up with and what the conversation is between the carriers and the Division of Insurance. Not that we would actually see that conversation, but we'll see what the results are this summer. So the difficulty became that CCIO does not recognize rider policies, that they cannot be certified as standalone dental plans. They actually have to be embedded in the plan. And because of that, the decisions that the committee made the board made, they don't work anymore. So the committee met for a total of 4 hours between May 9th and May 15th. We talked about embedding the pediatric dental EHB in a qualified health plan, bundling the pediatric dental EHB with the qualified health plan, offering QHPs without the pediatric dental benefit, replacing the rider concept with bundled plans, and mandating the purchase of the pediatric dental essential health benefits. There was a lot of discussion about where we were at with that decision, that we had moved away from the free market facilitator approach, that the elimination of the rider concept in combination with the prohibition to embed dental benefits meant that only licensed dental insurance carriers would be allowed to offer dental benefits through standalone dental plans. Furthermore, there was concern about the attestation requirement for reasonable assurance outside the exchange. If a carrier offers a medical plan that does not include the pediatric dental benefit outside the exchange, the carrier is required to have a reasonable assurance that a potential enrollee has also enrolled in a standalone dental plan certified by the exchange. Many states require an attestation about this, as we discussed earlier. The concern is that the attestation invites lying from those who enroll in medical coverage outside the exchange. If a carrier is allowed to embed the pediatric dental EHB in the qualified health plan, then if that QHP is offered outside the exchange, the carrier would not need an attestation because the dental benefit would already be included in the plan. As I stated earlier, there were some initial concerns about technical changes with less than 5 months before go live. The team has indicated, though, that they have already designed the system with the flexibility necessary to display these plans in the manner that the committee has recommended, so the technical issues are not a concern. One concern that is an issue is that carriers must submit their plans in less than 4 weeks by June 7th. Any change that further restricts carriers' options may drive carriers out of the exchange. They may not be able to recover in time to get the plan certified by June 7th. However, if we expand the carriers' options, that should not create any negative impact on the carriers. So we looked at several different options to replace the rider concept. One was to embed the pediatric dental benefit in a QHP. This option allows the risks and costs to be leveraged across the entire exchange market, regardless of the capability to use the benefit, which would reduce the premium. And that also goes along with the idea of requiring purchase of dental coverage when we get to the last section. We talked about embedding pediatric dental benefits, that they must follow the market rules for a qualified health plan. Because of that, an insurance carrier may be able to lower the overall plan premium by adjusting the cost sharing or deductibles for the pediatric dental benefit, and by lowering the overall premium, the carrier can be more competitive, obtaining more market share, and may drive more carriers to offer plans on the exchange. Additionally, embedding the pediatric dental benefit in a medical plan is consistent with the process off the exchange, allowing for statewide consistency. However, the rules allow for plans off the exchange to not provide the pediatric dental essential health benefit as long as a carrier has a reasonable assurance that the insured has purchased a certified standalone dental plan. So it could go both ways. Embedding exists today, and it's a continuation of current practice. It's in line with the free market facilitator concept. On the con side, a childless consumer purchasing the embedded pediatric dental benefit may not use that benefit, and there's a potential lack of transparency with that. Showing the embedded plans next to the non-embedded plans may drive consumers to go with the non-embedded plans due to the lower price, the expected lower price, and the price sensitivity of the market. This may give the standalone plans an unfair advantage. However, the web portal could be built to show dental premiums split out from the medical premiums. But this might potentially create an environment where a carrier can increase pediatric dental cost sharing and deductibles above affordability. However, we think that the discriminatory benefit design should mitigate this issue. Depending on the design of the shop and compare section of the application, a consumer may never know there are standalone pediatric dental plans that, by either paying more or paying less, can select the best plan for their children. We think that we've got some ideas to mitigate this, so the technical concern should go away. If all qualified health plans include the pediatric dental benefit, there would be no need for standalone dental plans in exchange. Because plans outside the exchange cannot exist without pediatric dental essential health benefits embedded or offered through an exchange certified standalone dental plan, this could eliminate standalone dental plans in the Nevada market entirely. This is a late change to the exchange policy. However, this is an expansion of the options available to QHPs and should not harm insurers that are in the process of creating plans that comply with current exchange policy. The other option is to bundle the pediatric dental essential health benefit with the qualified health plan. The frequently asked questions for this concept were released on May 9th, so we are learning this as we go. And it's no wonder that we didn't have the full information 2 months ago when we made the initial decision. The bundled option basically says you've got a medical insurance carrier and a dental insurance carrier, and they offer their medical QHP and standalone dental product together. Two separately licensed carriers. If they are the same carrier, there are concerns about single risk pool issues, and if it's a single risk pool, it's required to be embedded under the society rules. But as long as they are two separately licensed carriers, they could offer the two plans together as a bundle. This provides transparency of the pediatric dental benefit to consumers and can be offered alongside a non-bundled version, ensuring that they are aware of the pediatric dental benefit. The qualified health plan would be certified under qualified health plan market rules, and the bundled dental plan would be certified like a standalone dental plan. Therefore, the dental component as a separately certified plan can be priced using different actuarial values. That's the high, low, 70, 85% AV, as opposed to the metal tier 70, 80, 60, 70, 80, 90, and would have separate premiums and cost sharing would not have to coordinate benefits. And bundling exists today, and it's a continuation of current practice, and it's in line with the free market facilitator concept. The definition of bundling has slightly changed, but the idea is in practice today. On the con side, this may dissuade childless consumers to choose a non-bundled QHP to avoid paying for the pediatric dental benefit they will not use. Showing the bundled plans next to the non-bundled plans may drive consumers to go to the non-bundled plans first due to price sensitivity. This may give the standalone plans an unfair advantage. However, the web portal could be built to show only the medical portion of the bundle and then show the dental portion alongside other dental products. The next one is to purchase the pediatric dental only through a standalone dental plan. And this item is similar to what the board decided before, except it doesn't include the rider concept. Basically, we would not allow any plans to have dental embedded. Dental plans would only be offered through standalone dental plans. This would be the easiest display and the easiest selection process, the most transparent process. And it's extremely simple. You have your medical coverage, then you go to your dental coverage, and there's no combination of items. But as we said, technical issues, we've worked through some of those items. The cons to this: certain medical providers maximize their business models by contracting with dental carriers to either embed or bundle their products. This process dissuades those plans from participating on the exchange. A qualified health plan cannot leverage other synergies or manipulate deductible and cost-sharing market rule allowances to better price their medical plans on the exchange. And this process effectively provides 100% of the dental market to standalone dental plans alone, potentially limiting competition and plan variance. The next option on page 8 is to utilize the bundle option to replace the rider concept. In this option, it, I think, is most similar to the board's original intent. The pediatric dental essential health benefit would not be embedded in a qualified health plan. Insurance carriers who wish to offer the pediatric dental essential health benefit may do so as a standalone dental plan offered in a bundle with a qualified health plan or as a separate. Please, could you please put your phones on mute? So insurance carriers who offer a bundled qualified health plan in conjunction with a dental carrier that offers a standalone dental plan, and that's important to add, it has to be a separate licensed entity, must offer the same qualified health plan without the standalone dental plan, and I believe California has set that type of a model up. An insurance carrier who offers a bundled qualified health plan and a standalone dental plan may increase the number of qualified health plans offered in a given tier by 1 from the maximum of 5 up to 10 for each of the bundled plan offerings. So if you offer a medical plan and then you offer it medical plan bundled with a dental plan, we would allow you to increase that offering. So in effect, you would still have 5 medical plans, and each of those medical plans would have an option of a dental plan, and we would manage that through the IT system. The pros: it does not change current board policy. It provides for relative transparency of the pediatric dental benefit. It would be certified under qualified health plan market rules, and the bundled dental plan would be certified like a standalone dental plan. Therefore, the dental component as a separately certified plan can be priced using different AV and premium cost sharing than other QHPs, and bundling exists today. The cons is it does not allow for embedded products, limiting the market's ability to adjust to the new rules under the free market facilitator model, and may create an unfair advantage for standalone dental plan carriers. Again, this model would only work if you had a medical QHP with a separately licensed dental insurance carrier offering a standalone dental plan together. So of those various items, in summary, the committee recommended that the exchange allow purchase of pediatric dental through any combination of pediatric dental benefits embedded in a QHP, bundled with a QHP, or purchased as a standalone dental plan. So what that has basically done has opened up the plans that are allowed to include embedded plans. Finally, mandating the purchase of pediatric dental essential health benefit. There was quite a bit of discussion on this item as well. The committee discussed whether to mandate purchase of the pediatric dental benefit, and the mandate could apply to all enrollees or just to children. The following list, so we have the pros and cons. Pros, this potentially aligns with the off-exchange insurance carrier requirements. Prior to enrolling an individual in a plan that does not include the pediatric dental benefit outside the exchange, a carrier must have a reasonable assurance that the individual has enrolled in a certified standalone dental plan. The reasonable assurance standard can be met by an attestation, or, if CSIA will allow, a simple notification indicating that the medical plan does not include dental coverage. As we stated, there are 3 states that have gone forward with that option. We are not sure if that's allowed or not, but I believe the Division of Insurance is working through that discussion. If it's a simple notification, or even if it's an attestation, whether or not it is a true mandatory purchase is up for discussion, or is or up for confusion, if you will. We don't know if that's a true. While it says it's mandatory, it's incumbent on the carrier to request for reasonable assurance. It is not incumbent on the individual to actually purchase it. And if it's an attestation, they could be lying on the attestation, but there's nothing to prevent people from doing so. It ensures all children on the exchange have dental coverage regardless of parental choice. However, due to the calculation methodology of the advanced premium tax credit, the second cheapest standalone dental plan will be completely subsidized, which should ensure nearly 100% of enrollment in the dental essential health benefit for the subsidized population for children. Basically, if you have a plan, let's say you have a plan for $100 without dental, and based on the income and size of family, that family is supposed to pay $25. So that subsidy for that family would be $75. However, if you purchase the pediatric dental essential health benefit for the children, let's say that standalone product is $20. Again, these premiums are just for illustrative purposes only. But if it was $20, so the total would be $120. That family is still only required to pay $25, so that subsidy increases from $75 to $95. So we would adjust the display in the web portal to show that they received a $75 subsidy for the medical plan and a $20 subsidy for the dental benefit. And if you have a $20 benefit and a $20 subsidy, the net amount would be zero. We would expect nearly 100% purchase in the subsidized population. Outside the subsidized population, that would be it would be market rules, and we'd have to figure out what would happen. However, outside that population, you're up above 400% of the federal poverty level. So it would be in that case it would be optional. If it were a required purchase, then an individual could say, hey, I have to purchase it on the exchange. I don't have to purchase it off the exchange. I'm going to go off the exchange because I don't have to purchase it. So you could end up moving people away from the exchange if you require purchase. The benefit to having it a mandated purchase is that the risks and costs are leveraged across the entire exchange market, regardless of the capability to use the benefit, which would reduce the premium for standalone benefit for standalone plans. And I believe that Mr. Spain indicated that you would see an increase in cost. What that increase in cost remains to be seen for if you offer it as a voluntary product. The cons is that childless adults will pay for a benefit that they can't use. To mitigate this issue, the exchange could mandate coverage for only children. Restricting choice of consumers may drive them off or away from the exchange, as I discussed earlier. Carriers off the exchange are required to have a reasonable assurance, which does not necessarily mean required coverage. Therefore, if we design the web portal to require purchase, but an individual could purchase it off in exchange without dental, unsubsidized individuals would likely pursue coverage off of the exchange. And if you required purchase, you're restricting choice of consumers, which is in contradiction with the free market facilitator model. For this item, the committee recommended that the board select the optional purchase of pediatric dental benefits. So between those various items, the committee recommended options A3 and B3. The vote of the committee was, I believe it was 6-1. The one individual that was not in favor of the recommendation indicated that he was not in favor of it because he thought that purchase of dental should be mandatory. The rest of the committee, as I said, indicated that we should go with the fully free market facilitator model and allow purchase of dental either in embedded, bundled, or standalone dental plans, and then make that purchase optional. And with that, I'll be happy to take any questions, and once after the discussion, we'll talk about next steps.
John, just so you know, Marie Kerr joined the call just about the time you started your presentation. So would you please note that she has attended the meeting?
Yes, we will. Thank you.
Okay. Dr. Klein, since you work with me on this committee, do you want to make first comments or questions? Dr. Klein? Looks like we lost him.
Or he's on mute.
I'm right here. I'm sorry. I'm trying to. Patients coming in late at the same time. I'm sorry. Are we voting on this? Apologize.
John just finished his presentation on this, and I was asking whether or not you wanted to make comment on this because you sat on the committee with me.
My only point. I think John has addressed those points, which is that we're transparent in terms of in the embedded policies that were clear to people. What their deductibles are. So I trust the Division of Insurance will not have will not allow any policy that is discriminatory, but maybe even to be clear if there are different dental benefits or different dental out of pockets that we're clear on that. But other than that, I'm okay.
I also am in favor of opening up the different types of pediatric dental plans that can be offered either through the qualified as an embedded or bundled or a standalone project or plan. I think my concern on restricting something is that we might limit the number of carriers that come into the exchange. My personal view is I'd like to open it up and make sure that we get as many carriers in as possible in our first year. So do we have, and let me break this down into two parts. I think we ought to first discuss the different options for the different types of plans to be carried, and then as a second item, talk about required purchase issues. So do any of you other members have any questions on the embedded, bundled, or standalone medical plans, dental plans?
Madam Chair, this is Leslie Johnstone.
Yes.
John, I think you said this, but on the web portal, are you 100% sure that if we include embedded dental plans that we'll be able to make the separate benefits clear? I'm not concerned about the premium. I don't think the premium should be separated if they're embedded, but I would want to be 100% sure that we can make it clear to the buyer that one plan includes dental and what the conditions of that plan are versus those that do not include dental.
Yes, so the initial shop and compare screen, if you recall back from May, and you may have seen it in some of the presentations, the screenshot that we have is a horizontal rows of plans, and those will have a flag on them that indicate dental is included or not included. The choices indicate that they would have that. And then if you take those plans and you put them in the shopping cart, let's say you take 3 plans to do a comparison, and you hit compare, then you see those 3 plans side by side in a vertical format, and so it'd be medical deductible, specialist copay, family practice copay, or general copay, and then at the bottom you would see dental, and you'd see the dental deductible, dental copays, etc. For a plan that has it embedded, and for a plan that doesn't have it embedded, it would show NA or not not included. It would also have a help item on there at that point, or a flag that would say you have the option of choosing standalone dental plans at your next selection screen. So we are confident that we will be able to display those side by side.
Okay, and one more question, Madam Chair.
Yes, go ahead.
How would the web portal look different between an embedded plan and a bundled plan?
On the web portal, I don't think that you would really see any difference. You might see a difference in the name, but the plan benefits would be provided together. So it would, for the web portal.
Would both of those scenarios?
Yes.
In both those scenarios, would the premium be one figure?
That I'm not sure about. I think that if we offered it, if we provided that information broken out, we would try to break it out for both, but I'm not positive. But we would certainly have a place that would have the total premium that you would compare side by side. So I think on the display of the benefits, you would see the same. You would see this. It would appear to be the same. Whether or not the premiums are broken out differently, I'm not quite sure about.
Madam Chair, just one comment. I think it would be my strong preference that if we can, we do not break out the premiums for either one, because functionally it doesn't seem like that's relevant. And breaking out the premium would give me the impression that dental plan was optional in that policy.
We can put them together.
I think that's a good comment, Ms. Johnstone. I would concur with you on that. Do you have any further questions?
No, I was just trying to get an idea of the practical, end user view of things.
Ms. Kerr, do you have any questions? Dr. Ford, do you have any?
No questions, I'm sorry. I'm trying to get my phone to work.
Dr. Ford?
No questions for me, Dr. Ford.
Thank you. If there aren't any other questions related to the type of plans that would be offered.
Madam Chair,
Yes.
we have two ex officio members. I don't know if they have any comments. Ms.
Okay.
Joyner or Director Mullenkamp.
This is Amber. I don't have any comments at this time.
Thank you. It's Mr. Mullenkamp.
He may have had to step
All right.
away.
Okay. With that, do any of the members want to make a motion on this item?
Okay, Dr. Fine, I'll step up.
This is Dr. Ford. I motion to accept the advisory committee's recommendation for the exchange to allow purchase of the pediatric dental EHB through embedded, bundled, and standalone plan known as option A3, and leave purchase of the pediatric dental EHB as optional, option B3.
Dr. Ford, could we separate those two things and just look at the plans at this point in time?
Okay.
So,
So
for the
we're
record,
going to have you amend your motion just dealing with option A3.
Okay. I motion that the board take up the committee's recommendation for option A3.
Is there a second?
I'll second it. This is Leslie Johnstone.
Thank you. Do any of the board members want to discuss this further before we call for the vote? All right, John, would you take a roll call vote on this, please, since we're on the phone?
Yes. Ms. Johnstone,
Yes.
Dr. Klein,
Yes.
Ms. Kerr,
Yes.
Dr. Ford,
Yes.
Ms. Campbell.
Yes.
The motion carries.
Motion. Thank you. Let's go back to discussion then of summary item number B. The options to require the purchase of pediatric for all exchange members, for children only, or to make it an optional purchase. At the discussion at the committee meeting yesterday, and after listening to one of the committee members speak to the issue of the intent of the law, I think I have changed my mind on what my position would be on this. I think if somebody's purchasing through the exchange, the board should consider requiring the purchase of pediatric dental for children that have policies that are purchased through the exchange. I have the ACA calls for that as an essential health benefit, and for the exchange not to require the purchase for children seems to be at odds for me. And I don't know what any of the other board members may think.
Madam Chair, this is Leslie Johnstone.
Yes.
But just to be clear, the ACA doesn't require that it be included in the exchange offerings, just offered.
For the record, John Hager, it is required to be offered. The current interpretation by Socio is that it is not required to be purchased within the exchange, and this has to do with the exception for offering standalone dental benefits. And I can't recall if it's explicitly stated in the Affordable Care Act that it's optional, but the legal interpretation by CMS is that it is optional in the exchange.
Dr. Ron Klein, I would be supportive of making it mandatory for families with children to be consistent with what's offered outside the exchange. I think we heard public comment about the poor status of kids' dental health in Nevada, and I think anything we can do to improve that would be a good thing to do.
John, if you would clarify this for me, I think you talked about it a little bit. For our target group, which is the subsidized family, if they were to purchase a standalone dental plan or purchase a bundled or embedded, the subsidy is going to pick that up 100% if they stay at the silver metal tier at the second lowest plan offered. Is that correct?
That is almost correct. The APTC, so for the dental side, the standalone benefit, it's high-low, but it's basically the silver level, the 70%. So we would take the second lowest low AV plan and calculate the APTC off of the essential health benefit. If we require purchase for a family, I believe that there are portions of the health plan that would not be the pediatric essential health benefit because you would be covering adults, I believe. And so you would, at that point, the family, if you require purchase for families, you would be requiring that family pick up the cost of the dental benefit that is the non-pediatric essential health benefit. I'm not sure exactly how that works, and I've got staff shaking their head no's. Damon, can you provide some comments?
This is Damien Haycock for the record. My understanding is that if the board decides to approve that the purchase of pediatric dental essential health benefits for all children on the exchange, that option B2, if that it does indeed become the board's decision, then that means that the only the pediatric dental health benefit has to be purchased on that plan. And so if a bundled or embedded or standalone dental plan is offering a family plan, it's going above and beyond the pediatric dental essential health benefit, and then you're going to have a conflict. And I don't know if we can mandate that families purchase the adult portion of a dental plan when the adult portion of a dental plan that may be collectively placed in that embedded or standalone or bundled plan is not an essential health benefit.
So
I would try to keep things as simple. This dental thing has become probably the most complicated thing we've done, which is I'm not sure if that's a bad comment or a good comment, but I just think I would try to keep it at this point simple. So the ACA says we have to offer pediatric dental. It is required that you purchase pediatric dental. So I don't think we should mandate family plans. I think we should mandate pediatric coverage, to keep things consistent and as simple as possible.
This is Marie Kerr. If we were to mandate the pediatric dental, would the subsidy pick up the cost across all income levels that are subsidized, or are there people who would end up having to pay extra for the benefit?
for the record, John Hager, the way that the APTC is designed, the premium that a family pays is based on their income and their family size. And the subsidy is based on that amount subtracted from the premium of the second lowest silver plan, which in this case would include the second lowest dental plan as well. And so as long as a family that was subsidized was purchasing the second lowest the second lowest standalone dental plan, then the entire cost of that dental benefit would be covered from 138% FPL all the way up to 400% FPL. As soon as you get above 400% FPL, you are no longer subsidized and you would no longer receive the benefit of subsidization for that dental benefit. So keep in mind, if you are requiring mandatory purchase of the pediatric dental essential health benefit, I don't think that we can mandate it for the 400% below population and not mandate it for the population above that. It'd have to be exchange-wide.
Well, then I would suggest that it be optional. And you can certainly point out to the people who are at the 400% below Florida poverty level that it's completely excluded and they don't pay anything extra for it. So I think there's a way to set up the wording so that it would make it more likely that they would purchase it. But for the persons who go above that federal poverty level, perhaps that 40%, perhaps they'd want to purchase it somewhere else. And so I don't think we should make that mandatory.
This is Ron Klein. John, you and I spoke about this the other day. We're estimating 20% of people who purchase on exchange will be non-subsidized. Am I remembering that correctly?
I think that was somewhat of the guess. I would say, so I think in Nevada's population, approximately 25% are Medicaid eligible, 50% are APTC eligible, and 25% are above the APTC level. So if you're talking about exchange, that would be 2/3, except that I would expect that your uptake rate for the unsubsidized population would be significantly lower than for the subsidized population. So yes, I think that at 80% subsidized population, that would make that uptake rate twice on the subsidized population compared to the unsubsidized population. So 80% is probably a good round figure.
Just to address Marie's concern, and it was similar to a concern that I had that you and I discussed, we're talking about 20% of the population will be unsubsidized, and the only people we're mandating it for are going to be, the only portion that's relevant, Marie, for you that you're discussing is the 20% that's unsubsidized, and then the subset of that 20% that actually has children. So I don't know what that would be. 50, half the people are not. So we're really talking about 10% of the total people on the exchange who are unsubsidized with children having to purchase it. If we don't make it mandatory, we're going to leave a lot of federal money on the table because of the APTC that we're not going to get if people don't get it. Plus, from a public health standpoint, making sure kids have dental insurance, I think, is a good thing. So I appreciate Marie's concern, and I understand it, and it was my concern as well. But I think the good outweighs the bad with this by making it mandatory for kids.
Madam Chair, this is Leslie Johnstone.
Yes.
I have two, one question and one comment. Just to double check, this population that will be eligible for a subsidy, that's not 100% subsidy for all of them. So even those that have a partial subsidy, there's an added cost that's required. They're going to pay a share of it. Some of it will be subsidized, but not all of it for everybody. So unless I'm incorrect, I think we all need to remember that.
Okay.
And my second comment is, it's a question. Is there a discrepancy, John, between the age for pediatric dental being 18, I assume, and children being defined as up to 26?
Yeah, that's certainly a discrepancy. For rating purposes, I think it's anybody under 20 is a child, just to make it more complicated. You could perhaps mandate coverage just for those that are eligible for the pediatric dental essential health benefit. So that's one possibility. I believe Mr. Haycock has some other comments about this. I'm not...
Damon Haycock, for the record, there needs to be some thought across this discussion in regards to limiting the type of plans that dental carriers will be able to put on the exchange. There's a potential if the exchange board mandates the pediatric dental essential health benefit, and a dental carrier wants to provide a family plan, embedded or bundled or as a standalone dental plan, then the only way for if you take the example of embedded, then the only way for that family to meet the board's requirement to purchase the pediatric essential health benefit is to purchase that embedded family plan, and therefore they are being mandated to buy a non-essential health benefit product. If not, then you open up the opportunity for every dental carrier to offer, again, a multitude of dental plans, a child-only essential health benefit plan, and then a family plan. And then either of those have to be embedded or bundled or as standalone dental plans. And you may have a monster amount of plans on the exchange to meet this requirement.
And
I don't want to belabor this issue, but remembering the testimony from yesterday, and I believe it was Mr. Spain or the gentleman from Delta Dental, I thought they told us that the embedded would be pediatric only. And if the board wouldn't mind, I'll ask for clarification from one or two of those gentlemen if they're still on the line.
This is John Hager for the record. That would be up to the carrier to decide how they want to offer that. So, and I guess they could correct me if I'm wrong.
Mr. Spain, are you still on the line?
Yes, this is Dr. Spain for the record. From what I understand in talking to the other carriers, and what we intend to do is offer a pediatric-only plan that matches, again, the CHIP plan, which is what the exchange has identified as the approved pediatric plan. That plan is inappropriate for adults, and so no matter how you structure it, there's no way for us to assemble a family plan that would have a CHIP benefit level for kids and then try to somehow fold that into a family benefit. So the thinking has been both at Milliman and with us, and I'm assuming with all the others, that you would assemble essentially stacked pediatric plans, one for one child, two for two child, maybe a different rate if there were two or more children. And then if you wanted to buy an adult plan, you would buy the adult plan outside of the exchange to supplement for the adults. You wouldn't have to fold them all together as a family plan. In fact, it would be virtually impossible to do it because the benefit is not an adult benefit, it's a child benefit.
Is the gentleman from Delta Dental on the line as well?
Yes, can you hear me?
Yes, I can.
Yes, Jim Mullen with Delta Dental. I agree with what Dr. Spain was saying for the most part. And in particular, embedded QHPs cannot add any supplemental offerings above the pediatric benefit. And anything really supplemental is optional for the exchange to offer. So most exchanges, in fact, I think every exchange we are dealing with is allowing for supplemental dental to be purchased, adult only and family coverage. But they would be purchased separately from the essential health benefit. And it would be at the option, obviously, of the purchaser. CSIO has come out very recently and said that any supplemental offerings must include the pediatric essential health benefit, so that the childless adult who wants to purchase a supplemental benefit, the benefit that's available through the exchange would include the EHB. Now, the way that the dental plan would modify that is they would pay basically zero cost. They would know that there would be no utilization of the pediatric benefit, so they would zero cost that and really just charge for what the adult benefits are. But they wanted that because the family plan is meant to be inclusive of pediatric if the children are below the age of 19. And so, therefore, in other words, doing it differently would be you have to buy your pediatric essential benefit and then go to the supplemental and buy a whole new policy of just supplemental coverage. And CSIO has recommended anyway that exchanges incorporate the EHB into the pediatric dental, into the supplemental, so that the family then can buy one policy that covers everyone. Now, only those rules about the pediatric benefits, such as cost sharing, AV, deductibles, will apply to the pediatric dental benefit. But our plan, like many others, can distinguish that and rate for that separately. That the child 0 up to 19 is rated one way per member per month, and anyone above 19 who's an adult, even if they're a dependent, are rated separately without those other cost-sharing considerations. So while it's optional for the exchange to allow for supplemental, our plan, and I think other dental plans, can accommodate that. And what it mostly means is that the individual who just wants to buy the pediatric benefit has the option to do that and not buy anything supplemental. They can go get their supplemental coverage somewhere else, outside the exchange, anywhere else that they choose to buy it. They may have it through their employer for employee and spouse, but not children, and so they're already covered and they just want to cover the child. There'll be many different life experiences that will come to you in your exchange, and so I think you want to have as much flexibility there as you possibly can.
I don't know if that or makes it more confusing at this point. Dr. Klein?
Yeah, I'm right here.
Yeah, what is your inclination at this point?
I've said before, I'm more confused now than I've ever been before on the exchange. I guess I'm going to sort of fall back on just making things as flexible as they can, letting the market do what it wants to do, both in terms of. Oh, I'm sorry, we're talking about the pediatric. I'm still. I mean, it sounds like what was said was that they can take into account if somebody purchases a pediatric plan, that their family plan can figure that out in the process, if understood correctly. So I think I'm still in the place of requiring pediatric coverage, requiring people to buy pediatric plans who have children. And I think that's from a public health standpoint. I mean, you know, sometimes you can't get things perfect. Sometimes you just have to get them good. And I think from a public health standpoint, making sure the kids have dental coverage so they have good teeth to last the rest of their life, you know, outweighs some of the other concerns. As much as we hate to impose rules on anybody, our society imposes lots of rules on people, and maybe making sure that your kids get good dental coverage is one of them.
Dr. Ford, do you have any comments?
Well, the representative from Delta Dental, what I pulled away from that is very confusing to me, but what I think I got from that was that the insurers, specifically the dental insurers, are going to find a way to put plans up on the exchange that will satisfy whatever requirement we see fit. So I think it kind of brings us back to what is the board's pleasure in terms of making this pediatric dental EHB optional versus mandated. And I have to agree with Dr. Klein that from a public health standpoint, it's a no-brainer that children's dental health is incredibly important. And Mr. Hager's comments regarding how this could be subsidized by the federal government is very encouraging. I think the bulk of people on the exchange will get some sort of subsidy towards this dental coverage, and that's pretty darn good. And that's a pretty good thing, and I think it's in spirit with the Affordable Care Act. And I think that this is an opportunity for Nevadans to improve their status as number 51 out of 51 or whatever our rank is on this issue. So I would be in favor of making this a mandatory benefit for children 18 and under, 19 and under, whatever, you know, is the appropriate measure of a pediatric person. But I would be in favor of making it mandatory.
Thank you. Ms. Johnstone or Ms. Kerr, do either one of you have any further comments?
This is Leslie Johnstone. I'm going to stay with the optional purchase. You know, the market is the carriers as well as the buyers, and so I want to remember both sides. I genuinely appreciate the public health perspective, but we're just putting one more thing on plans that may or may not take advantage of it, or individuals that may or may not take advantage of it. And we may lose more buyers than we gain.
Ms. Kerr?
This is Marie Kerr. I have one question about listening to the discussion. If we were to make it optional, are we leaving federal money on the table, and how much? Is that a certainty?
For the record, John Hager, it's difficult to tell exactly. However, the way the APTC is designed, again, every person who is subsidized would be able to receive an APTC that is equivalent to the second lowest standalone dental plan pediatric dental essential health benefit. So we can separate out the children from the adults. I think they're required to offer I think there's a requirement to offer child-only policies. And so we can show the child policies separately, and those would be completely covered by the APTC. I imagine that there will be some individuals who don't choose it. However, it's difficult to imagine that many not selecting a plan that has no additional premium.
Okay, in that case, I would say make it optional. I make it very clear, and that's why we have the navigators and other persons to assist us with making it clear to people that there's no additional fee for it. And I don't think you'll lose that much federal money if that's made clear to people that there's no charge to get dental benefits. I think most people want dental benefits.
Okay. Well, does anyone want to make a motion?
We can always readdress it next year.
Dr. Klein, I will move that we make, if I can say this correctly, that we mandate coverage of pediatric dental health insurance for those people in the exchange with children. And I don't know if we have to specify age here, at an age that's consistent with an age that's consistent with other aspects of the plan. I don't know what the right answer is there. Can I just leave it as children and we'll figure that out, the rest out later?
Dr. Klein.
19 versus 20. Yeah.
Yeah, so we will make sure it works with the definition of pediatric dental.
Okay.
What I would recommend is instead of saying that it's mandatory for people with children, say that it would be a mandatory purchase for children.
Mandatory purchase for children. That sounds perfect. I amend my motion as the executive director has suggested.
All right. Is there a second to that motion?
This is Dr. Ford. I second.
Okay. Do members request any further discussion? And John, will you do a roll call vote, please?
Absolutely. Ms. Johnstone?
No.
Dr. Klein?
Yes.
Ms. Kerr?
No.
Dr. Ford?
Yes.
Chair Campbell?
Yes.
And the ayes have it.
All right. Thank you for good discussion among the members. Do we have any other items that we need to cover under agenda item number 4, John, or have we covered it all?
Yeah, just the next steps on page 10. There was some concern by some members of the committee that the current limit of 5 plans per metal tier per licensed carrier per service area is overly restrictive if medical plans include dental coverage either embedded or bundled. Though not fully vetted by the committee, it appears that there was a desire to increase the number of plans offered per tier by one for each QHP that includes dental coverage that a carrier offers, either bundled or embedded up to a total of 10 per tier. This would allow carriers to offer 5 different medical plan designs with and without pediatric dental essential health benefit included. Because of the limited time prior to the QHP submission deadline, staff will bring this item directly to the board within the next 2 weeks unless there's no appetite to change it. But I will say that it wasn't agendized, so we can't really talk about it a whole lot today other than to say that it's an option that we need to talk about.
Okay. Then would you please schedule it for the next meeting
Yes.
and put some staff recommendations together for that then?
And the next meeting is the legislative update meeting scheduled for Wednesday, May 29th at 4 p.m. That's basically 2 weeks from yesterday. We could either keep it then or we can move that up a week and discuss it, do the legislative update. It would be the last legislative update of the session and with this item, or we could leave it on May 29th. It's at the board's wishes.
I will be traveling the week of the 20th. So what day are you suggesting if we move it up?
If we moved it up, I would suggest Thursday the 23rd at 4 p.m.
This is Dr. Ford. I'm going to have a lot of trouble moving my schedule, so I may not be able to do that.
And I don't even land till 4:30. Why don't we keep it the 29th? Everybody's got it on their calendar. And John, is there? Well, I guess this is a critical issue, isn't it?
Yeah, we'll put it on the 29th.
Okay. All right, does that close agenda item number 3 then?
And item number 4.
Yeah. Does anybody, I think we've discussed already what we want to bring on to that next meeting. For the legislative update, we need to deal with the issue that John just discussed. Is there anything else that the committee wants to, or the board wants to bring forward at that meeting? Okay, hearing none, I'll move on to public comment. Is there anyone that would like to participate or testify in public comment?
For the record, Dennis Spain, I want to thank the board. This is a very courageous act you guys took today.
Thank you. Any other public comment? All right, hearing none, I will call for the adjournment of the meeting and I want to thank staff just like Mr. Hager did. I know that they've really done a lot of work on getting these things turned around and for the committee and for the board. Thank you, staff. We really appreciate it.
Thank you.
Everyone have a nice evening. And thank you. I will be talking to you then on the 29th of May.